After we treat a patient with LCH, we have to follow them for many years because there are long-term problems that are from the disease itself and perhaps also from the therapies. We know that about 20% of all patients are going to get diabetes insipidus. Some patients with bone involvement will have problems that lead to either changes in the length of their legs or problems with their spine, leading to some orthopedic problems. They might have problems in their lung or liver from the disease causing fibrosis that could affect the function of those organs. They might have hearing problems from involvement of the mastoid bone or around the ears. And of course, if a child has loss of teeth early on, it might affect the way the permanent teeth come in. There are problems with the eye, and very rarely there are associated cancers that we know that LCH patients have perhaps a slightly higher incidence of lymphoma and leukemia and maybe some other cancers, but it's not a very, very large percentage. We do like to accumulate knowledge about these cases to help us understand how the immune system may be impaired and give patients a somewhat higher incidence of these diseases. We've learned recently from some long-term studies with children that those with the disease in the mastoid and orbit and the temporal bone have these problems we call CNS risks that I mentioned earlier. And this is a special category of patients that we really are very interested in evaluating and following to see if we can prevent the long-term problems and learn what it is about their rate of change of the disease or amount of the disease at the time of presentation that would give us some hint as to why they would or would not get these difficulties. One of the first things that was learned was that the children have a high incidence of the diabetes insipidus, and when we looked back and found that if we compared patients who were treated just with surgery or one drug or radiotherapy, they had a 40% incidence of diabetes insipidus, but those that were treated with Velben and prednisone had a 20%. So that was half as many patients, and still quite a large number, but not as many as if we had only a single treatment. The really striking thing that we've learned about these individuals is that once they get the diabetes insipidus, other problems can occur. And one of them is neurodegenerative disease. So if you look at diabetes insipidus over all patients, it may be the presenting symptom in a few of them, maybe 1 or 2%. By 5 years, up to 10% are going to have diabetes insipidus, and by 15 years after diagnosis, overall it will be between 15 and 20% of all histiocytosis patients. But for those who have those CNS risk lesions, it's quite a bit higher, as I mentioned. And once they get diabetes insipidus, well, what else can happen? The diabetes insipidus happens because the back part of the pituitary gland is affected by the LCH. If the disease moves to the front part of the gland, then they have other difficulties, including growth problems, thyroid problems, and also their sexual maturation can be affected. In 2 studies, one from the French and one from the Histiocyte Society Data Center in Vienna, it's been shown that up to 50% of the patients with diabetes insipidus will get other endocrine problems. So that's the reason we have to be very careful about trying to prevent this and doing something about it once it happens. So this graph just shows that the risk of the other endocrinopathies occurring sometime after the onset of diabetes insipidus gets up to 50% by 10 years, but it's increasing gradually from the first year on. The neurodegenerative disease is really not well understood, and we think that it is really dependent upon the alertness of the physicians in following up. And the more we've talked about this, the more cases that are coming to our attention, because it's now becoming more generally known by physicians in the pediatric oncology community and also in the adult oncology group. So one way, the frequency of it depends on how closely we follow patients and how closely we look at them with special neurologic tests and MRIs. We found in one group of patients who were followed that had evidence of this neurodegenerative changes on their MRI films, that half of them had symptoms. And the symptoms mean trouble walking, ataxia, trouble writing, dysmetria, sometimes trouble talking, dysarthria. They might also have behavior or learning problems. When we looked at a group of diabetes insipidus patients, 76% of those had evidence of the neurodegeneration in the MRI that was done with follow-up of greater than 5 years. Not all of these patients had the symptoms of problems with balance and writing, but they did have some suspicious changes in their brain which need further follow-up. What causes this? There have been very few brain biopsies done in these patients, so we only have a limited idea. It doesn't seem like the Langerhans cells are hiding out in the brain and causing the problems, but rather T lymphocytes. Another part of the immune system has migrated into the parts of the brain that affect our balance and writing and speech and caused damage to the nerves there, such that the nerves have lost their insulation, and without the insulation, electricity shorts out, and so the nerves are not working, and this causes the problem with the speech and movement. This is a typical MRI image showing these white areas that are distinctly abnormal in the back part of the brain called the cerebellum. Occasionally, a radiologist who is not familiar with this condition might think this is scarring or evidence of a stroke or evidence of treatment-related problem, but this is a very characteristic finding in the neurodegenerative LCH. Some patients also get growth of some cells in the fluid parts of their brain called the ventricles and causing plugging up of the ventricles and what we call hydrocephalus, or water on the brain, where the ventricle gets way too big because it's like a lake that was dammed up and it gets bigger and bigger. Fortunately for this patient, with some chemotherapy treatment and radiotherapy, we got these masses to reduce in size. And in fact, he had some neurodegenerative changes which improved after the ARA-C, and he improved his writing and his balance and his learning abilities. So this is still a challenging disease. We've learned a lot over the years with our therapeutic studies that have been organized through the Histocyte Society, and there are a lot of very good research programs going on throughout the world today trying to investigate the cause of this disease and learn more about the biology. But until we learn more about the biology, we won't have specific therapies which really target the problem. So we have to find out what is the specific problem that is causing the disease so we can have those kind of therapies.